Hello, my name is Mina Rakowski. I am a transplant hepatology fellow at the University of Michigan. I've been asked by the editors of Clinical Gastroenterology and Hepatology to discuss a paper that will be published in the October issue titled MalloryDenk Bodies are associated with outcomes and histologic features in patients with chronic hepatitis C. MalloryDenk bodies, formerly known as Mallory bodies, are hepatocyte cytoplasmic inclusions found in several chronic liver diseases. Throughout this talk, I will refer to MalloryDenk bodies as MDBs. Keratin polypeptides 8 and 18 are the major constituents of MDBs and likely play an essential cytoprotective role in the liver. In mouse models, our group has shown that genetic background and gender play critical roles in MDB formation. In humans, we, as well as others, have demonstrated that certain keratin genes are associated with disease severity in chronic liver diseases such as PBC and hepatitis C. However, the clinical significance and prognostic value of MDBs, in particular development of MDBs over time, is poorly understood. The aim of our study was to identify clinical features associated with MDBs and to evaluate their role in clinical and histologic disease progression. To this end, we utilized a well-characterized cohort of chronic hepatitis C patients from the Hepatitis C Antiviral Long-Term Treatment Against Cirrhosis trial, better known as the HALT-C trial. This trial offered several advantages, including a prospective follow-up of a large cohort of over 1,000 patients, a wide range of races and ethnicities, and longitudinal data on alcohol consumption and metabolic factors. More importantly, serial biopsies were available, all reviewed by expert hepatopathologists. I will briefly summarize the HALT-C trial study design, which has been previously published. The HALT-C trial was a multi-center, prospective, randomized control study to determine if long-term treatment with pegylated interferon could slow disease progression in chronic hepatitis C patients with advanced fibrosis or cirrhosis who had previously failed interferon treatment. Patients underwent a baseline liver biopsy, as well as repeat biopsies 1.5 and 3.5 years after randomization, and were followed for clinical outcomes for up to 8 years. MDBs were recorded as present or absent. Because maintenance interferon treatment was found to have no impact on histologic or clinical outcomes, treated and untreated patients were combined, totaling 1,050 randomized patients. In our study, we assessed two primary outcomes, clinical and histological outcome. A clinical outcome was defined as an increase in CTP score to greater than 7 on 2 consecutive occasions, variceal bleeding, ascites, spontaneous bacterial peritonitis, hepatic encephalopathy, HCC, liver transplantation, or liver-related death. A histological outcome was defined as an increase in ISHEC fibrosis score by greater than 2 points on follow-up liver biopsies. This analysis included only patients with ISHEC fibrosis score less than 4 at baseline. We performed 2 primary analyses. The first was a cross-sectional analysis of MDBs on baseline biopsy. The second was a longitudinal analysis to assess the significance of change in presence or absence of MDBs over time. For the longitudinal analysis of change in MDBs over time, we analyzed 2 groups, MDB gain and MDB loss. MDB gain refers to patients in whom no MDBs were seen on baseline biopsy, however were present on follow-up biopsy. MDB loss refers to patients in whom MDBs were present on baseline biopsy but no longer seen on follow-up biopsy. Here are the results of our study. Of the 1,050 randomized patients, 158 patients, or 15%, had MDBs present on baseline biopsy. In the cross-sectional analysis, MDBs on baseline biopsy were associated with laboratory markers of disease severity, meaning low platelets, low albumin, high AFP, high AST-ALT ratio, as well as histological markers of disease severity, indicated by higher periportal fibrosis, pericellular fibrosis, steatosis, and inflammation scores. Presence of MDBs was also highly correlated with factors associated with obesity and insulin resistance, specifically presence of diabetes, high BMI, and high HOMA-IR. In the longitudinal study, multivariate analysis revealed that MDB gain was significantly associated with higher fibrosis and steatosis scores on follow-up biopsies, as well as presence of diabetes, female gender, and Hispanic ethnicity. MDB loss was found to be associated with absence of diabetes and being a non-smoker. Next, I will summarize the associations between MDBs and clinical outcomes. In cross-sectional analysis of the 1,050 randomized patients, 291, or 28%, developed a clinical outcome. Clinical outcomes were highly associated with presence of MDBs on baseline biopsy. However, these associations were not significant after adjustment for baseline variables associated with disease severity. In the longitudinal analysis, clinical outcomes were significantly associated with MDB gain after adjusting for baseline disease severity. The same finding, however, was not seen among those with MDB loss. Next, I will summarize the associations between MDBs and histological outcomes. In the cross-sectional analysis, presence of MDBs on baseline biopsy was associated with histological outcome and remained significant after adjusting for disease severity. In longitudinal analysis, MDB gain was associated with development of histological outcome and also remained highly significant after adjusting for baseline disease severity. This finding was not seen among those with MDB loss. Therefore, our longitudinal analyses found that patients with MDB gain had a greater risk of clinical decompensation and fibrosis progression. So what are the clinical implications of this work? By assessing over 1,000 patients with chronic hepatitis C, this study furthers our knowledge by demonstrating that MDBs are independently associated with fibrosis progression and that development of MDBs over time is highly associated with clinical decompensation and progression to cirrhosis. Interestingly, insulin resistance was significantly associated with presence of MDBs and development of MDBs over time. Specifically, MDBs on baseline biopsy were associated with the presence of diabetes as well as higher BMI, HOMA-IR, steatosis grade, and zone 3 pericellular fibrosis stage. In light of these associations, chronic hepatitis C patients with MDBs may have also had concurrent NASH. However, after controlling for several of the histologic features of NASH, such as steatosis and fibrosis, the presence of MDBs remained associated with histologic progression, suggesting that MDBs may offer additional prognostic information independent of its association with NASH. In conclusion, MDBs were highly associated with markers of insulin resistance, as well as independently associated with fibrosis progression in patients with chronic hepatitis C, which could be attributed to hastened fibrosis progression from coexistent NASH. In longitudinal analysis, patients with underlying diabetes appear to be at greatest risk of developing MDBs on follow-up biopsy, which was found to be associated with clinical outcomes as well as fibrosis progression. Therefore, assessment of MDBs in liver biopsies of patients with chronic hepatitis C appears to offer prognostic significance. Further studies are warranted to further delineate the potential pathogenic factors and clinical implications of MDB assessment. Thank you very much for your attention.